Welcome to Fire Your Doctor, episode 7, where we're talking about steroids. Or, that's what we're taking. She made these fancy titles for him now, and so this is news to me.
Well, we don't have to say the titles, they're just going to go on the thing. Inflamed, injected, and still in pain.
Okay.
Why relief today can mean regret tomorrow.
Wow, that sounds really good.
Sure, yes, yeah. It's a good one. So we're going to talk about steroids. My name's Dr. Danielle Lockwood. This is my husband, Richard Lockwood.
Hi.
Welcome. So we have this dilemma, right, about steroids because it both serves a purpose and causes damage. So we're going to read a little bit about that from our book, Fire Your Doctor. Thank you.
I'm using a coaster as a bookmark to differentiate between all the other bookmarks.
Yes.
Okay, yeah, let's go. Steroid medications include asthma medications, arthritis drugs, and some treatments for allergic reactions. If you're having an asthma attack or an allergic reaction, or you're in the emergency room, corticosteroids can save your life. Even as an outpatient, there may be narrow and temporary circumstances where a corticosteroid is the best option for the patient. Classifying drugs as good or bad is complicated. Even life-saving medicines can and do have real side effects worth considering. Short-term good must be weighed against long-term risk. In life, things that seem beneficial in the current moment can have negative outcomes in the future. Let's use debt as an example. A credit card can bail us out in a financial emergency, but debt is also a trap. There's profound wisdom in the quote at the beginning of the chapter. Chasing convenient fixes can cost us dearly in the long run. To be clear, steroids are powerful, life-saving tools. It's also true that the medical establishment and the public tend to downplay the side effects of treatments. This is not to say that steroids are good or bad. In fact, during the pandemic, I found myself prescribing more steroids than I ever thought I'd ever need to. Again, like debt, bad choices, even other people's bad choices, may force us to make hard choices in the future. And that is the end of the selection.
Wonderful. Well, first of all, let's back up. Let's differentiate between the steroids,
Anabolic
steroids and corticosteroids.
Right.
So there is a big difference. So anabolic steroids, when we want those natural gains.
This is natural, right? No, she's teasing me about a fitness podcaster that jokes about natty vegan gains when he's obviously anything but natty or vegan.
Yes.
No, but so that would be anabolic steroids that are going to mimic or increase testosterone, male sex hormones. Sometimes you loosely include other performance-enhancing drugs or PEDs into the loose category of steroids, even though they're not exactly a steroid, but they still will have like a muscle building or a performance-enhancing effect. In contrast, Dr. Danny, why don't you tell us a little bit more about corticosteroids?
So corticosteroids are a type of hormone that are made in your adrenal glands. And those are that triangle-shaped gland that is sitting on top of the kidneys. It helps to regulate inflammation. It helps to modulate in the immune system, stress response, and blood pressure. And there's two types of, we're going to talk about them. So there's two types. There's glucocorticoids. So I put the note sugar next to it. So if you are low in glucocorticoids, which are the type of steroid that leads to the production of something called cortisol or something called corticosteroid, which controls stress and inflammation, you're going to actually crave sugar.
Okay, well, wait a minute here. So we've got two main categories. We've got corticosteroids, and then we've got anabolic steroids, but you're dividing corticosteroids further into
subcategories.
Okay, sure.
So the adrenal glands make two major categories. One of them is called glucocorticoids, and then we've got aldosterone. So those are the two main ones.
Okay, great.
And they are stimulated by minerals in the category of aldosterone that controls blood pressure and salt balance. And so this would be if you're low in that and you're having issues with your blood pressure, you might crave salt.
Nice.
Very interesting, right? And then the glucocorticoids are going to make cortisol, and that controls stress and inflammation. And you're going to crave sugar if that's the part of your adrenal gland that needs a little bit of support. So we have this, people really want sugar and salt, probably because their adrenals are needing some support.
But the main category, I think that a lot of people, if they even think about corticosteroids, would be cortisone.
Mm-hmm.
And like those kind of related cortisol, cortisone.
Mm-hmm. Yeah. So in the glucocorticoids category, you've got cortisol and you've got corticosterone. And that actually leads to the making of cortisone. So it all comes from the adrenal glands. And cortisol is more of your longer term anti-stress hormone, right? But it can lead to a lot of inflammation, and it usually converts from adrenaline, actually.
Cool. Well, wait a minute. Okay. We might get in the weeds on this one. And this is getting a bit technical. How do these hormones affect people in their daily lives?
Well, they're really there to focus on those main categories I talked about, which is to quell inflammation in the body, to help bolster the immune system, and to just even out things like blood pressure or stress responses within the body.
Right.
Yeah.
There's a lot of, I think that sometimes when we think, well, this is what this hormone does, there's a tendency to think like, oh, well, I just need more of it or something. Where do you run into trouble with, say, cortisol in the body as an anti-inflammatory, let's say?
Well, that's going to be more for the short term. So you have adrenaline. That's like the hormone, that's the fight or flight hormone that's going to come out. We talked about in the previous episodes when you're, say, running from a bear, or you have a very stressful event.
Bears running from me.
Yeah, that's what we like to hear. And what will happen is you'll basically get the cortisol kicking in when, as a kind of subclinical thing that happens in the background when the adrenaline is kind of done. So the immediate response is that adrenaline rush, but then there's a conversion into cortisol, which sort of balances things out. But to remember, cortisol is not something that you want too much of, and it's also not something you want too little of. You want it to be in that sweet spot. You want it actually creates a beautiful curve, right? When you wake up in the morning, that is when cortisol should actually be the highest. It's called the cortisol awakening response. And what's interesting about that for my nerdy friends out there is the cortisol awakening response, aka the CAR, is really super helpful in preventing autoimmune disease.
Okay.
It's kind of cool. So just that rush of cortisol in the body will stimulate your immune system to go put a checks and balance off of autoantibodies.
So to put that on a bumper sticker, cortisol is a stress hormone. It is a response to stress, but without it, we would not be able to carry on basic functions in the body, notably the cortisol awakening response that happens kind of as you wake up and you go from this blissful sleep. Let's hope it was restful, and face the day and whatever challenges you have. And it's kind of like, okay, time to just ramp up, and the day's coming at you like a freight train. Yeah. So that's the cortisol awakening response.
And then through the day, we should actually see that cortisol response come down in this beautiful curve that starts to go down as the evening comes and helps the body to go into sleep. So when cortisol is low, then things like melatonin will start to kick in, and other relaxation type hormones.
Right.
What we see in reality, though, is you could have an inverse response where basically you're wired and tired. Your cortisol awakening response doesn't spike in the morning. It starts to spike in the evening. We've seen that, a complete reverse response to that. Just dropped a pen. So yes, cortisol can be completely reversed.
Okay.
You can have it completely opposite of what you would want it to be.
Okay. So let's talk about some common use cases that people run into corticosteroids. Sports injuries, allergic reactions, bee stings, topical rashes, things like that. Skin irritations. Let me see what else.
Well, first of all, let's back up for a second. So corticosteroids then are mimicking a normal steroid that's being made in your body. So that's why we kind of went back and said, well, actually, steroids are made in your body naturally.
Yes.
It's just when they're used synthetically, they can actually be very life-saving. In the case of, we'll talk about it in a minute, but in the case of COVID, when we had runaway inflammation in people, steroids were incredibly helpful in helping bring down that inflammation quickly. So in an emergency situation, if your body is healthy, it's going to actually pump out a bunch of corticosteroids basically to get that inflammation down and try to stop bleeding in certain cases, or try to bring down inflammation if you're having issues with your respiratory system, your breathing is off, things like that. That would be a natural response that your body would do.
Right. And so in emergency medicine, you would see, and let's make it a little bit broader, acute care, you would see corticosteroids as a very useful, sometimes life-saving medications. Somebody got stung by a venomous creature, something like that. Corticosteroids could save your life.
Absolutely. But going back for a second, when we talk about these are actually synthetically made in a lab, just to be clear.
That's how you know they're good.
And that would include things like prednisone. That would include
methylprednisolone.
Yeah, methylprednisolone. It would include even hydrocortisone.
Yeah. Something
like that.
Yeah.
So those might be one that you would think of. And most people, oh, what's the big deal? Just put a little hydrocortisone on it. Like, not a big deal. Steroids suppress a normal response within the immune system, and they can wreak havoc within the body.
Yeah, I think that gets into like a lot deeper discussion about, okay, so we tend to look at inflammation as bad. Like, I injured my knee doing jiu-jitsu, and now my knee has swollen to 3 times its normal size, such that I cannot move my knee. I need something to reduce that inflammation. She is pointing at notes, and apparently that's something that we're getting into in a later episode.
Yes.
But in any case, why don't you just go for it? Where are you going?
Well, no, you're absolutely right. So if there is an injury, the standard of care is to use corticosteroids on that injury, to use NSAIDs, which are non-steroidal anti-inflammatory drugs like Tylenol and Advil and ibuprofen and all of those things. So yes, that is the standard of care. We're going to talk about that in the next episode.
Yeah, basically, I'm just questioning the entire premise of why is inflammation all bad? I mean, obviously, if you're inflamed to the point that you can't breathe and some kind of an anaphylaxis, okay, inflammation, sit down, you've gone too far. But in general, that inflammation is also part of that healing process. It's part of an immune response. That there's a lot of things that would be good about inflammation.
Yeah. So talk about in the pandemic, you were with me, you were working with me the whole time. I mean,
yeah.
I talk about this in the book. I prescribed more corticosteroids than I ever thought I would ever prescribe in my entire practice.
Right. In general, I mean, your standard of care is more like, how do I get you off of these medications? How do I get you off of this? How do we figure out why is your immune system so upregulated that you are having all of these kind of autoimmune rashes, and how do we deal with that such that you don't need this thing as this continual crutch, but
to keep things under control.
Right.
And then the thing to also understand is anytime you're going to give a steroid, you're actually pressing that disorder deeper. So I always think of what
do you mean by press it deeper?
Yeah. So I think a pot with boiling water, what you don't really want to do is just put a lid on top of it. Right? It's like you always teach me blow the foam, right? To get it to
I did yesterday.
You did it and it worked. I mean, it worked.
Yeah.
And it brought that boiling pot down, but we don't want to just try to contain it. There is a time and a place for that. There absolutely is.
Yeah. Well, that's kind of what I was getting at with the crutch, is that we're suppressing a symptom. And if a symptom is to the point that it's very severe and the symptom is creating its own kind of health problems, you might need to suppress a symptom so that we can get at the larger problem. Unfortunately, what can happen in just kind of insurance-based healthcare is that getting rid of an unpleasant symptom is considered a heuristic for solving the problem. It's like, my knee hurts terribly bad. Let's inject it. My knee doesn't hurt anymore. Guess we fixed it. And it's like, no, that'd be kind of like taping over the warning light in your car.
Here's the situation. Let me walk out a scenario for you. And this is a very common situation that I see in my practice because I have kids who will come in the later stages of this process. So they'll manifest things like asthma or the eczema, like full body eczema. So how it typically starts is the kid is born. A lot of kids are born via C-section. So they're not getting exposed to, the normal microbiome flora. They may or may not have been breastfed. So they're not getting the immune system from the breast milk. So they might be formula fed. They're immediately bombarded with vaccines, which cause upregulation of the immune system. And we're talking about infants whose guts aren't solid yet, and pretty much anything can cross it. It's just kind of open to nature. And part of that is in its genius on the part of God is that he wanted us to be able to absorb all of those antibodies from breast milk really easily. We wanted it to be able to get into the system easily. However, as we have discussed, there's certain drugs and vaccines that contain things like aluminum or traces of mercury or other inflammatory factors that are inside them that some kids, not all kids, but some kids will hyperreact to.
Yeah, I think one of the problems is that breast milk does not have corn solids, and those corn solids are actually found in a lot of different formulas. And so that's going to be a big problem if your infant's not getting enough corn solids.
That is true. And that was very sarcastic for those of you listening. That was sarcasm.
Don't take my advice here. I'm playing devil's advocate.
There's a lack of building of that healthy microbiome, which we're going to talk about in the chapters later on. Yeah. But then the next thing that happens is they have a reaction, and the reaction is a skin issue, typically eczema or some sort of rash that starts to develop on their skin.
Nothing to do with all the corn solids you fed them.
Or the medications they're getting at an early age.
Completely unrelated.
Unrelated.
Yeah.
So you go see the doc. The doc tells you, oh, you know what? Just put a little hydrocortisone on it. No big deal. Just place it on a couple days and it should clear it up. Well, it does clear it up, actually, in most cases. But then it's weird. Like, then they start having colic and they start having acid reflux and they start having these other issues because the issue didn't go away. It just got pushed deeper.
Right. Well, and also a lot of times those topical steroids, steroid medications and creams, whatever, they'll come with pretty strict instructions, like do not take internally. And especially with pediatrics, like young kids, I mean, it's like, I caught my daughter with a Lego in her mouth. What are you doing?
Yeah.
So having that discipline to like not touch your arm and then touch your face, or not touch your arm and then eat something or drink something or put your hand in your mouth, like, especially for these young children that you're seeing, like that's going to be just almost an impossible ask to keep them from doing that. But let's get back to you wanted to talk about in the pandemic and COVID-19 and stuff.
I'm going to get there.
We're going to get there.
Finish this off because I think it's important, because later on how that thing manifests it might be eczema, but now at this point it's uncontrolled eczema that you're going to have to, and we'll talk about this on the next episode, which is eventually these kids go on what are called biologics, or where they're having to take these shots or IVs that basically shut down parts of their immune system long term in order to get this, quote, under control. But the truth is, we're still dealing with the fallout of that original use of the steroids and a immune system, as you said, that is so overstimulated that it's requiring these very tough, harsh drugs to keep it in check.
And then is it wise long-term to be suppressing large parts of the immune system to stop a narrow problem?
Not necessarily. My concern with them is the building research around the development of things like cancer and other autoimmune diseases, because you've cut off one part of this immune system and said don't react, but you don't know the downstream of that.
Right. That things aren't as narrow spectrum as you might like.
Yeah, exactly. Okay. And so when we were dealing with the pandemic, we were really dealing with these different stages And maybe you talk about that because you're really good at explaining the different stages of the pandemic, where people would originally come in with that kind of upper respiratory, mild kind of head cold.
This goes to something I was talking about at one of the earlier episodes where it's almost related to a die-off reaction, although maybe not quite so narrow. So the phases of COVID, I'll read from my own book. Number one would be viral replication. Your body doesn't necessarily know it's sick, and so it's not necessarily mounting a direct immune response to it. The virus is replicating inside of your body. And after that would come phase 2, which is symptomatic infection. This is when people might seek care if they were generally healthy in COVID. They might not seek care, or if they perceive themselves as generally healthy, whatever, they didn't seek care. And then what we saw early on in the pandemic, particularly, would be an intermission. And this would be where I was talking earlier, where the body feels like we won the war. The battle's over, war's over, because we've defeated COVID. Unfortunately, virions, viral particles, things like that are still physically inside the body. And so then we would go into phase 4. Sometimes in the literature, you'd get it called the late pulmonary phase, but it's basically an inflammation phase where your body would start, in some people, would start reacting to deactivated viral remnants of COVID still located in the body. Kind of just imagine all the kind of flotsam and jetsam of the broken apart virions and viral DNA floating around in the body.
In that stage,
Yeah.
I learned from this doc, one of the frontline docs during that stage, was that there was a hyper serotonin response.
Yeah, there's a lot of funny things.
It was very interesting. So a huge amount of the neurotransmitter serotonin would be released in the body, which would cause respiratory distress, lots of inflammation, hypoxia, which is a lack of oxygen, blood clots.
Lots of blood clots.
And one of the things that he suggested was actually a antihistamine called cyproheptadine that I had no idea about, but
so antihistamine meaning
it was an old antihistamine.
Well, anti-inflammatory, right?
Yeah, but actually no, because it actually blocked histamine response, so it had nothing to do with that particular thing. But serotonin would trigger basically mast cell activation, and that's why we see a lot of long COVID people that have this hyperhistamine reaction. And what we're finding out is that people have a lot of parasites.
What were some of the corticosteroids that would be used in this late inflammation phase? What was your reasoning and what was your outcome?
Well, I would either use a combination of methylprednisolone, which is a higher dosed steroid, and then I would slowly taper it over a few days. And I also use prednisone. So if they were really in trouble, I'd have to kind of work them up to a higher dose of prednisone. Mm-hmm. We would also use inhaled steroids like budesonide, which were really great because they could deliver the anti-inflammation to the lungs. Very good for people with asthma who got COVID and really had a terrible time with asthma attacks and things like that.
Right. So basically, in that case, we weren't necessarily trying to cure COVID. It was more just like this person's having a runaway inflammation reaction. And we need to buy time. We need to buy a week. We need to buy a week and a half so that they can kind of process all of these just viral debris in their body and just recover on their own. Exactly.
So we were just really about focusing on keeping them alive long enough to get them well.
Okay. So you have in one of your notes here that you're calling steroids a necessary evil.
That's true. Okay. Because typically I wouldn't use steroids, but in this particular case, it saved lives.
Right. Where in that case, just a temporary reduction in these, in this case, dangerous symptoms could actually lead to a far different clinical outcome.
Well, what we were finding was the mainstream system's recommendation for steroids, they were giving people like half a child's dose of steroids. And as you know, if at all.
Yeah.
And then they would say, well, steroids don't help or they don't work. And that's not the truth. You actually had to hit much higher doses.
I think there's a deeper conversation, though, where what we see is we saw insurance-based medicine, mainstream medicine, kind of going against their own standard of care.
Yes.
So describe that, like corticosteroids, that is, are fairly common in mainstream medicine. And then all of a sudden in the pandemic, what was their response with corticosteroids?
They were told that it didn't work, even though it's worked in other cases.
As in doctors and nurses working at hospitals.
And nurses were told, well, that doesn't work during COVID. This is a different thing. Don't do it. And the reality is, if they were allowed to do it, as I said, they were using such low dosages. And in the studies, we saw that as well. They were using the wrong dosages, and these people were not getting better, and they were getting worse. And the inflammation was just like a runaway train. It was awful.
Right. I think part of that just, it feels a little bit like kind of a sophistry, or kind of a hiding in the details and just kind of overcomplicating an answer. Mm-hmm. Because the question was not, do corticosteroids, do asthma medications cure COVID? That was never the question, but it was almost like mischaracterized as that. And it was like, well, of course, corticosteroids won't cure COVID. Why are you even asking? That's a dumb question. Get out. Whereas your goal as a physician isn't necessarily to cure that. Your goal is to have a patient live to the end of your shift.
Yes, exactly. Well, and for me, it was just buying time, because eventually the immune system would kick in and take care of what they needed for the most part, as long as they got oxygen, that they didn't have a blood clot, messing with the ability for them to get oxygen. Mm-hmm. And so it was really about anti-inflammation, and in some cases anticoagulants, breaking down the blood clots.
Yeah, that was another kind of factor that we saw, where it's like, well, I guess they just died. And you would see patients, essentially having either some kind of a deep vein thrombosis, maybe a stroke, kind of CVA type thing going on. And it's like, well, COVID's a killer. I guess that just happened. And similar to the steroids, it was like, well, wait a minute. We have heparin, we have other anticoagulants, we have different things. Like, treating runaway inflammations and allergic reactions and these types of things are very common in a hospital setting. Mm-hmm. So this is very common. This is something that they know how to do. And it's like, if I come into the hospital and I got bit by a snake, okay, sure. Or I got stung by hornets. They don't necessarily have to know the exact type of hornet or what I got into, or maybe I'm allergic to shellfish and I just, whatever, I made the mistake of eating sushi and got exposed to something like that. There's a way that even if I was nonverbal and whatever, that the hospital should be able to treat that anaphylaxis or that runaway inflammation reaction, and probably successfully, without even knowing exactly what I was exposed to or how I was exposed to it. Do you think that's fair?
100%.
Right.
We had a patient who we ended up having to send to the hospital. And part of the success of being able to send this person was that I coached the daughter of this individual in how to talk to the hospital staff in a way that they would understand. For example, she had blood clots. So no.
The patient had blood clots.
The patient had blood clots. So it was talking to them, can you give me anticoagulant medication like heparin or Eliquis or something? Okay.
No, that doesn't cure COVID.
That doesn't cure COVID. No, but I need the blood clots treated. So we had to talk to them very simply like that. I would like my blood clots treated. Okay, next. I would like oxygen because I can't breathe. Okay, next. Yeah. I need respiratory therapy to recover. Can you give me an antibiotic for the secondary pneumonia that has developed because the blood clots have prevented?
Well, how do you know COVID's not a bacterial infection? Like, okay, let's get a culture.
Yes. So it's like we had to coach them through step by step in their own standard of care.
As in coach family members, or even in some cases, speak with hospital physicians.
Yep.
To tell them and just kind of call them back to what they should already just know how to do.
Call them back to their
own standard of care. Right.
Just what they would do. I want you to treat this as if, in this particular case, this was a patient who had already been 12 days after COVID. So that they were in that late stage
Right.
hyperreaction that happened very rarely with most of our patients because we treated them early on.
Early and aggressively, yeah.
And this was one that kind of came to us a little bit later. And so we ended up having to send them to the hospital because we needed them to be hooked up to heparin. Like they needed anticoagulants.
Right.
So, but yeah, we had to exactly call them back to their own standard of care is what happened.
Yeah, call the hospital back to their own standard of care, meaning you don't necessarily need to know why an inflammation is happening or this reaction is happening to solve it. And in fact, in emergency medicine and these types of things, maybe you don't have that luxury of time to just, I guess it's just happening. Let's spend the next 6 weeks investigating it. It's like, no, this patient's not going to make it the next day unless you solve this blood clot.
Yeah.
And so I think that this was a hard chapter to co-write just because it was, in other ways, maybe a very easy one, but it was so difficult because there was such a level of cognitive dissonance that we see on the one hand, this hospital system and this, mainstream healthcare system that is so in love and just enamored with these steroids and just passing them out to everybody and your kid for all these reasons, just like, guess it's autoimmune. We don't really know why. It's just happening. Let's just give them a corticosteroid.
Yeah.
And then all of a sudden when we're in COVID and you're like, hey, listen, these corticosteroids that you guys love so much, this could actually save this patient. And, that doesn't cure COVID. It's like, I'm not asking you to cure COVID. You need to get this patient to live for the next day, the next week, the next month, and eventually their body's going to survive COVID.
Yeah. Yeah.
And so that was such a level of cognitive dissonance to see this system that commonly uses these medications, and then just to completely forget everything they know about their own standard of care.
Yeah. So calling them back to their own standard of care. Yeah. So there is a time and a place. It was a necessary evil. We used a lot of steroids during COVID for a lot of different patients, hundreds of patients, and used it successfully to bring them through that acute phase.
Right.
Many of them have gone on to be longer term patients of ours and we've worked to address the underlying high level of inflammation that's there through diet, exercise, and dealing with their stress properly.
There's also kind of an evidence trail that one could reasonably predict, at least in hindsight, the link between corticosteroids being effective to treat the late inflammation in COVID and also who was at higher risk for COVID. So who was at highest risk for COVID?
People who were obese and had diabetes. Those were the highest risks for COVID. Or they had previous, heart blood pressure condition, especially people taking the drug lisinopril, which is one of the top blood pressure medications because it inhibits the clearing of the lungs. That's why they get that lisinopril cough as a side effect of that blood pressure medication. Mm-hmm. So they were at risk. Who wasn't at risk was smokers, actually had a really low risk of having issues. And that there's a whole reasoning for that because of the nicotine, and the nicotine would push the spike protein off the receptors. So it would help it from getting into the cell as easily. Not that I encourage smoking, but they were in that low risk category. And other people, autoimmune disease, they were already on high alert enough and their immune system was sort of dysfunctional enough to where they downregulated some of those inflammatory responses that we would typically see in autoimmune cases. I was worried about autoimmune patients, but they did not seem to be or have the issue.
Some of the autoimmune patients, though, were already medicated. If I'm remembering one of the cases in particular that was very complicated, they were already being medicated with corticosteroids and even the biologics and stuff like that. But so let's see, where was I going? I think there was something else there. Oh, yeah. So somewhere I heard you say that diabetes can be well understood as an inflammatory condition.
Absolutely. Yeah. And so when I say all of these things, I'm saying generally who's the most inflamed. And it was people
obese, blood sugar issues, pre-diabetes or diabetes. That's going to kind of set up that the person that's kind of barely squeaking by in terms of inflammation, like they're on the edge of being very inflamed on a good day, all of a sudden you give COVID and now they've got to clean out clean out this viral infection. And now their inflammation's like really in trouble to the point that the body can't compensate.
Exactly.
So in retrospect, there is actually a very clear kind of logical steps that would like lead you towards like, oh, okay, yeah, this is actually going to be all about inflammation, which is, you know, another thing. I mean, there's been some good books written already about the pandemic and kind of the failed response to it. But that would be one thing that everybody could have done very early was get healthier, lower inflammation.
Well, even the study on vitamin D, if you had vitamin D in the 30s or above, which I don't even consider that high, 80% reduction in the chance of you being put on a ventilator.
Well, ventilators were a death sentence.
Just vitamin D, and walking was another thing. So one of the things that people who got COVID did not want to do is they did not want to move.
Yeah.
And that put them at risk for clots and more inflammation. And that was not good. So if you would have just had people take high dose vitamin D, walk around, you know, one of the things, and that patient that I mentioned before, one of the things that we couldn't get her to do, she was older. She did not want to walk and move. And I was like, you need to get her up and you need to have her walk around. And that's when we really started to figure out how bad off she actually was because of that. So yeah, those were some things, simple things to do that really made a huge difference during the pandemic.
Walking and even doing simple like sit to stand exercises are also very important in detoxification. I don't think we're talking about the lymphatic system in this, but there's a lot. If you've got all this kind of just inflamed tissue and things like that going on, there's entire like your muscles and soft tissues and things like that. One of the only ways that they're actually going to get that all that inflammation out of that and all that intercellular fluid is going to be engaging major kind of core and your leg muscles and things like that to just kind of essentially pump out. Would you say that's fair?
That's fair. Yeah, it's absolutely fair.
So I could definitely see how just getting up and walking every few hours, even if it's just kind of walking around your living room, would absolutely make a difference in an outcome versus sitting in a hospital bed.
Yeah. We would do so much differently if we knew better.
Oh, the huff cough exercise too. That was a good one. There was a lot of good stuff.
We did a lot. We incorporated a lot of things, and many of these things were, again, standard of care for people with pneumonia in the hospital, or standard of care with people to reduce blood clots, and so again, I don't think it was anything crazy that we did.
Yeah.
It was just how we did it and just following the lessons of people who were on the front line, telling us what to do and helping. Of course, God was very influential in that for me. And all of those things.
Speaking of God, there's a kind of a biblical principle where it's like, the Lord will take the things that the enemy intended for evil and use them for good. And so I think there is this way that, people think that Goliath was killed by a rock, and it's like, no, he was actually killed by his own sword. He got knocked down by a rock from David, and then David took Goliath's sword from him as he was knocked to the ground, and then finished him that way. And so there's almost this kind of irony or a poetic justice that you took up the enemy's weapon, as with your background in Chinese medicine, etc. Corticosteroids are about as far as you could get from a holistic remedy as possible, but in a way, by just, honestly, obedience to God and just serving the patients in front of you with whatever they needed, even if it went against kind of your natural proclivity in natural medicine. It was like, no, I will actually use that enemy's weapon, those corticosteroids that are overused on a daily basis, and use them to save a life when the big players wouldn't.
100%. And let's be clear, there were people, thousands and thousands of people that died needlessly from COVID.
Oh, absolutely.
And negligence within the hospital and gross abuse in the hospital. And we know stories about that. And we did what we could do.
Yeah. I think also that fundamentally, I know the book's called Fire Your Doctor, and it's like we could go pretty hard on doctors, but there's also this way that there's a principle that happened during the pandemic, and that was going away from clinicians treating out in the field, and this mindset that doctors treating patients directly would kind of see what was working, see what wasn't working, and report those findings up the authority ladder. And then public health policy would be decided based on the kind of consensus of what was working out in the real world. In the pandemic, however, we saw an inversion of this to the detriment and the deaths of many, where doctors in the field were saying, hey, these ventilators aren't working. They're not working. This treatment isn't working. Remdesivir is killing people and ruining people's kidneys. And they were told, shut up or you're fired. And so we saw this kind of switch to an autocratic, almost like a dictatorship, top-down model of medicine.
Yeah.
So
there was so many things. So if you read our book, you'll see that our book is actually dedicated to the people who stood strong around this and lost their licenses and lost their careers over it because they cared more about saving lives and doing what was right than to following the autocratic orders, as it will.
Yeah. So
yeah.
Here we are. We're out corticosteroiding the fans of corticosteroids. So
that's it. Well, thank you. We will see you on our next episode where we will talk more about corticosteroids and we'll go even deeper.
Awesome.
All right.
All
Bye.
right. See you soon.